Hi, my name is VK Gadi. I'm a medical oncologist and a breast cancer specialist. I'm also the Deputy Director of the University of Illinois Cancer Center here in Chicago. And today I'm joined by my dear friend, Ruta Rao. Maybe Ruta, you can introduce yourself first.
Hi, my name is Ruta Rao. I'm a breast medical oncologist at Rush University Medical Center, where I hold the title Professor of Medicine. I'm also the research lead for our breast cancer program, and I'm delighted to be here today with you.
Awesome. And we're very good friends. I've known you for, I feel like, a long time now. And is it okay if we just go by VK and Ruta?
Yes.
Okay, perfect. That makes it easier. Today we're here to talk about updates related to trastuzumab deruxtecan. And it's been a big year for that particular molecule with all these readouts and trials, but I kind of want to drill down a little bit and talk about what happened at ESMO. There were two big trials, Destiny Breast 11 and Destiny Breast 5. And if you don't mind, maybe we'll start with 5, and then you can tell me sort of a little bit about your impression, study design, that kind of stuff, the usual stuff that you might tell your patients or colleagues and things like that.
Sure. So Destiny Breast 05 was a study looking at the patients with residual disease after neoadjuvant therapy. We know that based on the Catherine trial, our standard of care has been to use T-DM1 in that setting. So we know that the Catherine trial showed us an improvement in disease-free survival as well as overall survival for the patients. And the idea was to see if T-DXd in that setting could even improve upon that. Based on, I think, a few things. One is that we know that there are still certain groups of patients who are at a very high risk of recurrence with residual disease, even despite getting T-DM1. There are certain groups of patients like those who have node-positive disease who have even up to a 30% risk of recurrence. So we really can do better for those patients. In addition, we know that the risk of CNS metastasis is something that T-DM1 doesn't seem to really reduce. And given T-DXd's activity in the CNS, that's another question that I think all of us who practice breast cancer are wondering whether that could reduce the risk of CNS metastasis for those patients.
Yeah, especially in the last point you were making, if just going back just a little bit, Destiny Breast 12, which is this open label study looking at patients, many patients with breast cancer metastases in the brain with HER2 positive disease in the metastatic setting, we could see clear activity of the agent in that setting. So I think this hypothesis that it could have an impact in the early stage setting was a sound one as well. You said a couple things, so I just want to unpack a little bit. You said that this trial looked at patients at high risk of recurrence. So in your mind, what is that? Because to me, I'm just thinking anybody that's got residual disease is, quote, at high risk, but we know that's not entirely true. So what does that mean to you?
Right. So I believe for Destiny Breast 05, it was the patients who were deemed high risk of recurrence based on the fact that they were either inoperable at onset or their residual disease had node positive disease involved. So that's really how they pulled out the high risk patients. So I think it's really important to keep that in mind, that this is for a specific group of patients, because those are the patients we're really worried about recurrence in.
So this is hot off the presses data, like the papers, everything. We're still all processing the presentations on the podium and everything. So have you been able to talk to a patient about this yet?
So I haven't had a patient yet who is in this situation. I have a couple people who just finished their neoadjuvant TCHP and are having surgery this month. And they were both node positive to start with. So I think I will consider it if they have node positive
persistent disease in the nodes.
Yeah.
So I define high risk in a variety of different ways. Certainly what you just said is part of it. But when you think about the study and you looked at the patients enroll, what are other high risk characteristics that maybe the trial didn't address directly? Are there any other patients, like really young patients or things like that you would also think about? Or how we define inoperable is a little funky as well. Some people say that's inoperable and others like, I can get it. So what would how do you approach some of those edge cases, so to speak?
Yeah, I think that's a great question. I think we will need to see the paper to see how they defined inoperable, but that's what I saw from the ESMO presentation, is that they just said inoperable. Right. But I agree that sometimes can be a judgment call. I think we definitely know when patients are inoperable, but there's some of those patients that our surgeons say, well, I'd prefer if you gave them neoadjuvant. Right,
exactly. So that's where I was going with that.
Yeah.
And then, there's other ways to define high risk now. I'm going out on a limb here, but some of us use things like ctDNA, for example. And if you're persistently seeing that, is that going to influence your decision making, or are you just going to stick with, as you move forward, with what the patients who got on the study would be the same patients in your practice?
Right. So I think it's really, in this case, a matter of balancing the toxicity versus the efficacy. So I think that's where really trying to figure out who these high-risk patients are. We know in the study itself, the ctDNA was not used as a marker of high risk. So I think, will that be one day what we're using, and one day in the not too distant future? Possibly. But right now, I'm not using it in my practice to define those patients at high risk. And I think because I don't use it, it's not something I would consider in that way. But I do see your point as to young patients or, some of these other patients. I think whenever we have these adjuvant therapies that we know significantly improve outcome, sometimes we're like stretching the limits a little bit of who's on the trial.
Yeah, once it gets in the real world, it's
Yes.
all, and I think that's where we get asked questions oftentimes is, everybody can read the trial and get a sense of what to do, but then they're going to ask us about these things, and you're like, oh, wow, that's a great question.
Right.
Going back one more point, I guess, like we talked about the brain metastases just a little bit, and I found that to be compelling. There was a difference already notable, but there were still some patients in the T-DXd arm that did have brain metastases. My understanding, because it's a global trial, et cetera, is that everybody didn't have screening.
Correct.
So did some of those patients already have CNS involvement that we didn't know about? Like, I'm asking this question to myself. So how are you going to approach that sort of
I think it was remarkable even early on to see that there was numerically a lower number of brain CNS recurrences, brain mets in the T-DXd group compared to T-DM1. But I think you bring up a great point. These patients weren't screened. They weren't screened, and they didn't have routine CNS testing on this trial. So really, any of the CNS imaging was done based on investigators' discretion of patients getting new symptoms, which is kind of what we do in real life in practice. But it would have been interesting to know if they had been screened and followed for that. Yeah,
and because it's such a global trial with patients being enrolled from all over, really, it's hard to enforce mandates like everybody gets an MRI at enrollment. So I understand the practical feasibility issues around that, but I do think in our U.S. population, it'll be an interesting conundrum. We'll see how we navigate that.
Right.
So the other thing, of course, obviously, we're excited about the efficacy difference. If I remember, it's, hazard ratio in the 0.5-ish area. So we're cutting down half the events that we anticipated in a high-risk group. So that's very exciting. But the flip side, of course, is patients have to get this drug. And maybe you can tell us a little bit about like how many cycles and what did you remember about that?
Sure. So it was done, similar to how we give T-DM1 a la Catherine. So the patients were randomized to 14 cycles of T-DXd or 14 cycles of T-DM1. We know in real life as well, not all patients are able to even finish their T-DM1. And I think that's what we saw in the trial as well. I believe it was about 20% who didn't complete the prescribed therapy.
And I think the median cycles between the two arms was dead even.
Yeah,
which is funny to me because a lot of people, they tell you, oh, TDM1's an easier drug to be on. But at the end of the day, the same number of doses, got delivered to the same, on the same, across both arms. So that at least sort of washes out, I would think.
Right.
Yeah.
Right.
I don't think people can nitpick and say, oh, this group didn't get as much as that or what have you. So that I think is an important point.
Yeah.
And then in terms of the actual toxicity profiles, I looking at the data, didn't see anything new that caught my attention. Did anything stand out for you?
I think the toxicity was very consistent with what we've seen with T-DXd. The rates of nausea were higher, but now we know how to manage that nausea with T-DXd.
Yeah.
In our practice, we use 4-drug antiemetic regimen to manage that. The rate of ILD with the 14 cycles was pretty consistent with what we've seen in the metastatic trials. I believe it was about 10-12%.
Yeah.
So again, not unexpected, something we definitely know to look for. What I found was interesting was that the patients could receive their adjuvant radiation if they were candidates for it sequentially or concurrently with the T-DXd.
Right.
And it didn't seem to increase the incidence of radiation pneumonitis.
Yeah, and of course, the way we do radiation, especially in the United States, is so refined, right? Like we have such careful planning, delivery of the dose. We know exactly where it's going. That may not be the case everywhere. So I would argue that maybe our outcomes could even be better in the United States, where we have all this technology to assist our patients in making sure we're not harming them with radiation as well.
Great point.
Yeah. So, in terms of the experience that we identify for our patients that's one thing. But then there's what the patients are going to report. And to my knowledge, I've not seen any of the PRO data, but I think that'll actually be another important component. If, it's easy for us to say nausea is easy.
Agreed.
But our patients may have a different viewpoint on that.
Agreed.
So, I think that's important, really, and especially in this case, that's really important data to get and digest as well.
And I think the other interesting thing will be alopecia. Yeah. Because I think, a lot of these patients cold cap through their neoadjuvant therapy, and when they go on T-DM1, they don't have to really worry about losing their hair. Yeah. But with T-DXd, I've seen it be very variable. Some women just get a little bit of thinning, and some women lose a lot of their hair. So that may be, one of the patient-related outcomes that we should look for.
Yeah, we'll keep an eye on that.
And definitely something we have to talk to patients about.
I'm a little hair loss insensitive, as you know. We've talked about that. So. All right. Well. That was a really nice summary of DB11. It's nice to hear another expert kind of having the same sort of thoughts as I'm having. I've informally already had a few patients where I've thought about this, and I've reached out to my network, and most of us are saying, yeah, go for it. So it's kind of interesting. I think one of the other challenges right now is we do have patients that have just started T-DM1, and you're like looking at them going, should they still be on T-DM1?
Yes.
And I don't know what to do with those patients, honestly. Right. That's where I'm struggling. I don't know if that's something you've also faced.
Yes, absolutely. Yeah. Especially considering, the patients who have positive lymph nodes, residual disease in their lymph nodes still, I should say. Yeah. Those are the ones that I'm thinking, I wish this had come out a little earlier. But, one lady I have like that is right at the end of her T-DM1. So it's kind of hard to think about switching midstream.
Right. And then, we have the potential for other disruptive clinical trials in this space. So I think it's just a really rich area of research, and we're going to get a lot of answers pretty soon.
Yes, absolutely.
So that was the easy one in some respects, because it's clear, replace this one with this one. Now we have DB11. So same thing. Can you maybe tell us a little about DB11 and try to frame it a little bit in terms of what they do in Europe and what they do in the United States, because I think that's actually an important distinction for this particular trial.
Sure. So again, with the success that we've seen with T-DXd in various lines in the metastatic setting, the idea with DB11 was to bring it into the neoadjuvant space. And we really haven't seen T-DXd in this space before. So this was actually a 3-arm trial. And so the standard arm here was AC followed by THP, 4 cycles of each. And I think that's where you're kind of talking about the differences in different practices. I think typically in the US, we're not using AC THP anymore. We're using more of a TCHP regimen and anthracycline-free backbone. So I think, we could get into more detail there about how does it compare to our current standard of care. But regardless, that was what they used in the trial as the standard of care arm. And then they had a arm of T-DXd for 4 cycles, followed by THP for 4 cycles. And then the third arm was actually T-DXd for 8 cycles. Right. And that arm was discontinued early because of the low PCR rate. I believe that PCR rate was around 40, 43.
40s, yeah.
Which, in one way you could look at it as still a pretty remarkable PCR rate for just getting an antibody drug conjugate.
Yeah.
But we know that with our chemo, HER2-directed therapy combinations, our PCR rates are typically higher than that. So I believe that's why it was discontinued early.
Here we're talking about just 4 cycles of this new drug, exciting drug. Obviously, we're getting really compelling PCR rates, better than what we expect even with the standard of care. And then on the back end, we don't have the long-term outcomes, right? The event-free survival outcomes, the overall survival outcomes. So there's a little bit more speculation here about what that'll look like. Putting all of that aside, here we are in the United States. You're in clinic, you have a patient. High risk, do you roll the dice and kind of go with the DB05 sort of backbone this is what I could do? Or are you so motivated by these PCR rates to start thinking about incorporating these strategies now, today?
I think, that's really the question we're going to face in clinical practice, and it's going to be a very tough one. I mean, on the one hand, the PCR rate with the T-DXd followed by THP was so impressive. And if you get a path CR, then these patients don't need any ADC in the adjuvant setting. Right. And that's wonderful. We know that just getting trastuzumab or the HP combination in the adjuvant setting is definitely much easier for these patients. So, I think a lot of us will be tempted to kind of go for it at the beginning. I think really the question's going to come up if we do that and they still have residual disease, then how comfortable do we feel giving T-DXd in the adjuvant setting with residual disease because that's not how DB05 was done.
Correct. Well, and then the other scenario that I've heard just anecdotally around talking to folks is they say this: I wish they gave the T-DXd first, right? And I get that sentiment, but is there a world or a scenario where you think, I'm going to give T-DXd first, see what happens, and then give AC? I mean, I don't what would you do in that scenario? Like, you can clinically monitor these patients, you can do an MRI and see how the breast disease is being modified by that first agent. But
I think in an ideal world, that would be a great way to do it. I think what was really appealing to me about this trial is that it was 4 cycles of T-DXd, as opposed to, if you're asking me to choose between one and the other one having 14 cycles, we know the toxicity are higher. If you could get a path CR with, a DB11 approach with 4 cycles of T-DXd, I think that's a huge advantage for your patient.
Well, and then it goes unsaid still, but if we're worried about neoadjuvant therapy, residual disease, and brain metastases, then here's another opportunity to sort of nip that issue in the bud if you give the T-DXd earlier as well. So, Yeah, and then in terms of, you brought it up a little bit, I'm assuming we're still going to have to face the same kind of in-the-moment toxicities like nausea and growth factor support, et cetera. Did you see any safety signals that worried you with the neoadjuvant approach?
No, and actually what I thought was very interesting was that the rate of ILD was very low, I think about 5%. And relatively similar actually for the AC-THP arm. And we don't really think about ILD for AC-THP, and I wonder if it's just because it was being monitored.
You're looking for it.
Yeah. So how much of that was, are we just missing because it's not clinically significant and we're not monitoring those patients?
Yeah, and in my experience when I've been giving T-DXd, the ILD, it's rare for me to see ILD within 4 cycles anyway. So you may just be obviating that concern even altogether, which would make life simpler for a lot of people as well.
Agree, especially when we're talking about the number of scans we need to do to monitor for it, for these patients. I think it would be really nice to have a 4 cycle regimen where it's very effective.
Yeah. Now let's say this all gets taken up by the guidelines. Bill Gradish, our good friend, says, yep, and puts them all in there, and so you guys figure it out. Let's say that happens, and you're now giving the DB11 type regimen, and a patient does have residual disease in that scenario. Do you give more DB11? I mean, do you give more T-DXd, or do you go over to TDM1 at that point?
Yeah. I think that's when I'm going to call a friend and I'll call you and say, hey, BK, what should I do? But, I think we'll be tempted. Like, if there's a little bit of residual disease and these were patients who were very high risk to begin with, we might say, well, if we had given just a little bit more, maybe would that have all been gone? So maybe in a patient like that, I'd be a little more tempted to do T-DXd. I'm not sure of what the efficacy of TDM1 would be after T-DXd. I think we just, don't have a lot of data on that. Certainly not in this adjuvant space. So I think that is going to present a real clinical conundrum for us.
So leaning into that just a little bit, how do you, in patients who are getting neoadjuvant therapy, regardless of the disease subtype, how are you monitoring your effectiveness in that moment, prior to surgery?
So typically with physical exam. And for most of these patients, because most of the patients we give neoadjuvant therapy to are HER2 positive or triple negative. And generally they respond really well. If I have any concerns on exam, we'll do imaging.
And imaging is ultrasounds or MRIs?
Ultrasounds or MRIs. Some of these women who are very young with very dense breasts, the mammogram and ultrasound didn't show a lot. So sometimes we are doing MRIs. And then, obviously I'll have the surgeon see them halfway or 2/3 of the way through. And then their physical exam really matters to me too, because I've been seeing this patient much more frequently. So they haven't seen them in a number of months. And if they are concerned about any progression and taking into account how the patient feels. So I have a very low threshold for getting any sort of imaging, but I wouldn't say I do it routinely.
So what I didn't hear you say was ctDNA. So I'm bringing that back up here. So as you know, and many doctors are doing this with what I would consider sort of at the moment, low sensitivity assays for persistent disease during neoadjuvant therapy, but we're on the precipice of getting higher sensitivity assays. So if you had a way to get a peekaboo look using something like a molecular, marker like ctDNA, will that influence how you're going to incorporate in the HER2 positive space? Is 4 cycles of this enough? Do I need 8 cycles? How are you going to, do you see a world where that's possible for you?
To me, that's kind of our ideal world where we could use some sort of molecular testing to tell us that we've, really cleared the
breast.
Yeah. And the molecular residual disease, that's what we're worried about in terms of recurrence, correct?
Right.
I just don't think we're there yet because we don't really have the guidelines to say if it's persistent, we escalate in this way. If it's not persistent, we can de-escalate. Maybe they don't need any additional therapy. So I think it's probably where we're headed, but we need those trials.
Yeah, and that data is, it's good, but it's thin, right?
Yeah.
It's from things like I-SPY 2,
yeah.
which is small series of patients. It's not robust
Right.
in terms of having hundreds and thousands of patients. So yeah, it's early, but I think the truth is doctors are being marketed these tests and they're starting to use them, even if the academics are sitting on their hands a little bit and waiting for higher levels of evidence.
Yeah.
We clearly see community physicians and others, rightly so, they're trying to take care of their patients.
And I think they're more used to using them in colon cancer, in CML, other malignancies where, it's kind of part of their routine.
Yeah, we're learning from them.
Yes.
Yeah. Just bringing it all together, we have these 2 approaches, it seems. For some patients, we may have the conversation where we're going to incorporate chemotherapy followed by T-DXd surgery and then figure out what we do after that with the knowledge that a large proportion of those patients are going to clear their disease. But if they have residual disease, a big open question mark, do they get more TDM1? Do we do something else altogether? Hopefully there's a clinical trial for those patients.
Right.
But then there's going to be other patients where we're going to look at them and go, hey, we're going to roll the dice. We're going to give you standardized neoadjuvant therapies. We're going to get you to surgery. And then if we get to surgery and you have residual disease meeting these high-risk characteristics, we're going to offer you T-DXd. Did I summarize that correctly?
Yes.
All right.
Yeah.
And I think there's pros and cons to both approach. At the end of the day, the people who make T-DXd win. Everybody gets T-DXd, right?
Right.
And did I miss out on anything, or is there any other last comment in this early breast cancer space?
No, I think it's such an evolving space. I think, it's really great to have all these trials showing us such wonderful results for our patients. But now it's really kind of taking it back to the clinic on Monday morning and what are we going to do with the patient in front of us?
Yeah. So Ruta, thank you so much for that early breast cancer summary. Before we sort of completely leave for the day, I want to pivot just a little bit because the other big elephant in the room is
DB09. Yes.
So with DB09, maybe you can tell us, that was from ASCO, of course, where we learned about that readout. Maybe you can tell us a little bit about what that trial was trying to do. And I don't want to call it controversies. It's a disruptive trial in a good way. But how is that going to influence us?
This trial was looking at T-DXd in the first-line metastatic setting for HER2 positive metastatic breast cancer. And this space has really been held by Cleopatra regimen for many, many years now. That's been our standard of care.
Yeah.
THP, a taxane with trastuzumab and pertuzumab. So this was comparing T-DXd with pertuzumab, at least this is the results we saw, T-DXd with pertuzumab compared to THP. What we haven't seen yet is the T-DXd alone arm. But it again showed superiority of T-DXd with pertuzumab to our THP regimen. I think none of us were surprised to see that result because, T-DXd has been superior to standard treatment almost in every line it's gone up against.
Pretty much everywhere you've tested. Yeah.
But I think it does bring up some questions. One being that on this trial, patients were continued on T-DXd with pertuzumab until disease progression, whereas the Cleopatra patients, the patients on the THP arm treated like the Cleopatra regimen could stop after, I believe, 6 cycles. They could stop the chemotherapy and then just go on to the 2 antibodies and add endocrine therapy. And we know we have other data in that space showing that a CDK4/6 with endocrine therapy after stopping the taxane did benefit a great number of patients who are HR positive and HER2 positive. So I think
so that's a patina trial that you're referencing there.
Yes.
Yeah.
So I think again, it puts us in a good place where we have choices, but it does make our life a little bit harder.
Yeah, and so I've heard a lot of docs talk about the patina trial. Interestingly, we've had the DB09 study, at least the portions that have been reported out, presented in the New England Journal very recently, late October, I think.
Yep.
We're still waiting on patina. I know that paper's under review as well. But once all of that is out, once the NCCN guideline looks at all of these things and starts populating these options for us, do you think you're going to approach certain patients differently, i.e. the ER positive, HER2 positive patients differently from maybe the others, or will you have sort of a one size fits all? Like, have you thought about that yet?
I think we're going to all end up with much more individualized approaches. I think somebody who presents with metastatic disease with a very high volume of disease, maybe even CNS mets at presentation, I think that for a patient like that, it's clearly T-DXd or T-DXd plus pertuzumab would be my treatment choice. But if someone is very strongly hormone receptor positive, maybe their volume of disease is low, they are de novo, they haven't had any treatment before, it would be really nice to be able to give them 4 to 6 cycles of THP and then follow that up with endocrine therapy and palbociclib, like patina. So I think we are going to have to make some choices and individualize it to patients, their comorbidities, their disease burdens, and frankly, what their goals and desires are.
Yeah. Do you see a world where there's hybrid approaches where you do a little bit of induction with this and then switch over to that? Yeah.
I think that's what a lot of people are going to do.
Yeah.
They're going to kind of take, because we're not going to have any trial like that coming out, maybe ever, certainly not.
Well, there's the European study that's going to look at that, because for regulatory reasons, they need to have evidence to be able to pivot back to HP. Otherwise, they can never go back to it.
Oh, interesting.
So they're in a unique situation. So we will get data for that, but it's not, it's
not immediately.
Not immediately. Yeah. It's going to take a little bit of while.
So I think a lot of us in the HER2 positive metastatic setting are used to giving this sort of induction regimen with chemotherapy, and almost even advising our patients that way, that we're going to do a certain number of cycles of this and we're going to take the chemo drug off. So just kind of push through it, and then you'll go on the 2 antibodies alone and your life will be much better.
And just to play on that a little bit, with the taxane-based approach, we often don't treat to best response. We just sort of give 6 cycles, and sort of call it good or whatever. With this other drug, with T-DXd being available, do you see the same sort of paradigm? I'm just going to give X number of cycles, or I'm going to go to best response? Like, again, we're speculating.
Yeah.
You haven't done any of this.
I think it's going to be a question of when we stop it.
Yeah.
Because it's such an effective drug. But, if you look at any of the T-DXd in metastatic breast cancer trials, the response rates are so high.
Yeah.
So I think this is a drug that we're going to see really great responses in the metastatic setting.
Well, and to that point, we saw CRs at a much higher clip than we saw with THP.
And we don't even expect CRs in the metastatic setting. So, so I think we will probably be a little surprised when we start to use it first line, and, may think about doing it to best response, and that best response may come a little earlier than we're used to.
Yeah. Now, I've also pored over that paper a little bit. I didn't particularly see any data signals in terms of safety that were different or shocking or new, and I'm assuming you didn't highlight anything either. So again, lots of nausea, so we just got to do a good job of taking care of that. Have at it. Any other ideas on all of this? Like, what are you looking forward to? We're about to head into San Antonio next week, actually. You'll apparently be on the same airplane as me. But what do you think we'll be expecting to see there in terms of this space? Is it just more kind of supportive data like PROs? Or are you anticipating other readouts?
I actually don't know.
You don't know?
No.
That's a perfectly fine answer.
I'm actually not sure. I know that, in the HER2 positive space, we do have some other trials that are coming out, especially looking in the residual disease setting, looking at TDM1 with tucatinib, which is another drug that's active in the CNS setting. There's also another trial looking at using a checkpoint inhibitor, atezolizumab, in that setting. So I think we will have potentially some other options depending on how those trials read out. And we won't have any comparators. So we're going to have to make some decisions.
And we are also all anticipating HER2-CLIMO5 as well, which in the metastatic setting is another maintenance strategy that's available to us. So like three options there, whereas we had for the longest time just a single option. So
agree.
Good headaches, I guess.
Yes.
All right.
Yes.
All right. That was a lot. Lots of stuff in the neoadjuvant, adjuvant setting, but there was some other important information that came out in the metastatic setting. In particular, I'm focusing on DB09. I know it was way back at ASCO in the summer, but maybe first you can tell us a little bit about that study, how it was designed, put together, who was the target population.
Sure. So DB09 was a study looking at T-DXd with pertuzumab in the first-line setting for metastatic HER2-positive breast cancer. And this is a space that's really been held by the Cleopatra or the taxane plus trastuzumab pertuzumab regimen for the last very many years.
Yeah, THP. Yeah.
Exactly.
So Ruta, with regards to DB11, obviously we've got the PCR rates. Maybe you can review those real quickly, but also we don't have a lot of other data, right? Like we don't have EFS and OS, and those are important too.
Right. So we definitely saw an increase in PCR rates. There was a delta of about 11% for the patients who received the T-DXd followed by THP. Specifically looking at the hormone receptor negative group, their PCR rate was above 80%. So that's really remarkable PCR rates that we've seen.
Yeah. So we've got DB11 now. It's cooking. We're eventually going to get things like the event-free survival, EFS rates, and the OS rates. But what are the current benchmarks we got to get above to make this a positive trial? Like maybe you can tell me a little bit more about what we get out of our current TCHP in terms of PCR rates, EFS, and where are we benchmarking and what do we got to exceed with DB11?
Sure. So, what I think we see in the best possible case scenario with our current neoadjuvant trastuzumab, pertuzumab containing regimens is a PCR rate in the high 50s, low, possibly 60%. So that's really where we're looking at. We know the PCR rates are higher in the ER negative, HER2 positive patients. So on the DB11 trial, we did see a significant increase in the PCR rates for the entire group of patients. The delta there was 11% between the two groups. And specifically in the ER negative patients, the PCR rate was even above 80%. So I found that to be quite remarkable.
Yeah, and benchmarking is a little hard because those studies truly in the prior era in the neoadjuvant setting were set up to then allow us to do a proper adjuvant trial, right? That's where we get affinity. Those days are kind of long gone because we now know we can get EFS and OS that's meaningfully different in the neoadjuvant setting long term. So yeah, we'll see how this plays out. We're flying a little blind in this regard, I think. So we've talked a little bit about all these benefits from potentially getting a DB11 type approach. But are there patients that maybe you wouldn't think about this, or is this a one-size-fits-all option?
Yeah. So again, this was a trial more directed at the high-risk patients. So the patients either had to have large tumors, T3 or higher, and they could be any nodal status in that case, or they had to be node positive. So I think we do have to be pretty selective about the patients we're putting on this trial. And I think we're used to that in clinical practice because we do know that we have a de-escalated regimen like the APT regimen, which some of us are giving adjuvantly or neoadjuvantly using one chemo drug. So again, I think we really have to think about who are the higher risk patients, and definitely those patients with the larger tumors and the positive lymph nodes are patients I would think about for this.
Yeah, I mean, in the truest sense, those low risk patients, the small tumors, node negatives, if it ain't broke, don't fix it, right? We're talking 8-year OS rates that are astronomical with single low digits of recurrences and deaths. So it's hard to make that better with a much more toxic regimen.
Yeah, I think we just have to make sure we're not under-treating but not over-treating as well.
Yeah, that's precision medicine at the core, right?
Exactly.
All right. Well, thank you. This has been fun. I mean, we talk all the time, but it's kind of nice to just sit together and kind of go through some stuff. And hopefully the folks listening in learn kind of what people in Chicago are doing, and we can teach the rest of the world.
Great. Thank you so much.
Absolutely.